Good evening. In the next few minutes, let me take you all through a diabetic retinopathy screening program which we at Little Flower Hospital, Angamali undertook along with the government and the Queen's Diamond Jubilee Trust through the Public Health Foundation of India. I have no financial interests. In fact, this is a tripartite project between the Public Health Foundation of India, the Government of Kerala, and Little Flower Hospital, Angamali, which was implemented in Thrissur district. A little bit of background about Little Flower Hospital, Angamali. This is the largest and the oldest non-governmental organization working in the field of eye care in Kerala. And we have been instrumental in having so many of the community ophthalmology programs in the state over the last 50 years. Public Health Foundation of India came in the form of the Queen's Diamond Jubilee Trust Fund, which was the aim of the trust was to establish a diabetic retinopathy screening program across India, and 10 districts were selected across India, and one of these districts happened to be Thrissur district of Kerala. And we utilized the government services, the government facilities, and for that we had to take the government of Kerala into confidence for this. Why we did this project? Because the global prevalence of type 2 diabetes is 422 million. The incidence is rising in the low and middle income countries, including India. And Kerala, it happens to be the diabetic capital of India. The diabetes mellitus prevalence nationwide is 17%. Diabetes mellitus prevalence in Kerala is 17% against a national average of 8%. That means Kerala is very rightly called the diabetic capital of Kerala. The prevalence is 11 to 19% in males and 15 to 22% in females, and what we see in our hospitals is just the tip of the iceberg. Of these, the two districts when we compare all these districts, the two districts of Trivandrum and Ernakulam have one of the highest prevalence rates of diabetes when compared with the other districts in India. The Kerala paradox is that rural Kerala has a higher prevalence than urban Kerala, while the national data shows the figures are double in the urban areas than in rural areas. In Kerala, of course, as all of you have seen and read, the literacy rate is very high, but the health literacy rate is not so good. And the high prevalence of diabetes mellitus is also attributed to poor detection rates. When we come to diabetic retinopathy, the global data is about 30% of those with diabetes have diabetic retinopathy. In the Indian studies, it's almost like 7.3 to 26.2% of diabetics have diabetic retinopathy. We didn't have a population-based study from Kerala in this decade, and there's a positive literature regarding the prevalence and patterns of diabetic retinopathy. This provides us with quite a few opportunities. We have the effective screening tools. We take fundus photographs with a handheld non-mydriatic fundus camera and transfer the images through teleophthalmology. We integrate all these images. Kerala has a strong public health care system at the primary level, that is a government health care system, and each of these have a non-communicable disease clinic. So this non-communicable disease clinic functions on specified days of a week, and it is through these NCD clinics that we do the screening. There is an effective communication at the network of grassroots level workers, that is ASHA workers, Anganwadi workers, and village health workers. And the strategy was to explore the potential for active screening and early detection of diabetic retinopathy in Kerala by making use of existing public health networks for access to the grassroots level. Here I introduce something called a 5-photograph concept of patient education. We have 5 photographs when we talk to a patient. For each eye, the first photo, I'll go to that in the subsequent picture. The first photograph is of a normal eye. These 4 photographs are permanently there. First photograph is of a normal eye. Second slot, we insert the patient's fundus photo. Third is of a diabetic macular edema. Fourth is of a proliferative diabetic retinopathy. And fifth is for a vitreous hemorrhage. The message which we would like to convey is, your eye should look like that in the first photograph, and right now it is looking like that in the second photograph. If you don't take care of your eyes, if you don't go through a screening and treatment program, it will be like the third photograph of DME, or the fourth one of PDR, or the fifth one of vitreous hemorrhage. That means blindness. That is a message which we convey to the patient. which we have the similar set of photograph for the right eye and the left eye as well. So act fast and save your sight. That is the message conveyed through these photographs. We analyzed the effect of integration of the existing non-communicable disease clinics in the government hospitals for early detection and treatment of diabetic retinopathy using teleophthalmology. And as I said, this was a population-based screening in Thrissur district of Central Kerala. The healthcare workers at the primary health center, the Taluk headquarters hospital, and the general hospital were trained on diabetic retinopathy by the base hospital team. The entire ophthalmology team was trained, that is starting from the optometrist, the counselor, to the doctor, to the ophthalmologist. An optometrist and counselor visits the NCD clinic of these hospitals initially hand in hand with the optometrist of the government hospital. Visual acuity testing was done. Fundus photographs of all diabetics using non-mydriatic fundus camera was taken, and most of these were screened and shown to the patient by the optometrists themselves, and those without a retinopathy were just given a health education and sent off from there, while those pictures which had to be transferred were transferred to the base hospital and reviewed by the ophthalmologist in the base hospital. Diabetic retinopathy versus no diabetic retinopathy was identified by the optometrist on the field. Doubtful images are verified by an ophthalmologist, and as part of quality control, random checks were done, that is 20% by a fellow in retina department and 5% by a consultant in the retina department. Those requiring further evaluation was referred to the higher facilities in the government sector or the base hospital. That means the government sector was slowly becoming strengthened by the training imparted at the base hospital to the optometrists and the ophthalmologists of the government hospital. So gradually we started sending these patients to the government hospital, and which could not be managed at the government hospital, to the base hospital or the mentor hospital. As part of the statistical analysis, we saw an analysis, compared the gender, age in the follow-ups, the association between diabetes mellitus and the severity of diabetic retinopathy or PDR, and the results were, this was the mean age, the male to female ratio was 44 to 55, and this was the demographic characters. Prevalence of diabetic retinopathy, what we screened in the NCD clinics was 11,298 patients, and 1,116 diabetic retinopathy was detected there. That was almost 10% of the diabetics. Out of which 727 or 80% were NPDR and 187 or 20% was PDR. When this was the block-wise distribution, and again, the association between duration of diabetes mellitus and chance of having a PDR, a patient with more than 10 years duration of diabetes has 2.76 times chance of having a PDR than that with less than 10 years duration of diabetes. Then the association between the follow-up status and the development of PDR, a patient with regular follow-up for diabetic mellitus at the NCD clinic has 0.3 times chance of having PDR than those with an irregular follow-up. Prevalence of diabetic retinopathy among diabetes patients attending NCD clinics of Kerala is almost 10%. The duration of diabetes and chance of having PDR has a significant association. There is a significant association between irregular follow-up at NCD clinics and a chance of having a PDR. And there are a few missing links in service delivery. The age and gender are not significant, while factors associated with the follow-up status of diabetes at the NCD clinics are significant. High rates of PDR and NPDR at detection is a cause of grave concern, and diabetic retinopathy was a condition which was getting less attention in the NCD clinics of Kerala. To conclude, newly detected diabetic retinopathy among diabetic patients screened through NCD clinics is high. 80% had severe form of retinopathy at detection. Even after attending NCD clinics, diabetic retinopathy including PDR is largely undetected. Longer the duration of diabetes, significant is association with PDR. Patients with regular follow-up at NCD clinics have lesser chance of having PDR, implying better glycemic control. So the suggestions are, need an integration with ophthalmologists at NCD clinics. An awareness has to be created among health workers for increased early detection of diabetic retinopathy. And the government sector has been equipped for, at least in the pilot district, the government sector has been equipped with the equipments. The study was conducted, the screening was conducted, and at the end of the project, the entire equipments have been transferred to the government sector. The government doctors have been trained to do FFA, OCT, injections and laser. Training of all cadres, that is the paramedics, have been done along with this. The challenges, ophthalmologists, the stability is in question, because as once you train an ophthalmologist and he or she is capable of managing diabetic retinopathy, as part of the government transfer program, immediately he or she is shifted to another hospital. That is one challenge which we face. Optometrists and ASHA workers have been trained to pick up these diseases. And as part of the recommendation from our part, diabetic retinopathy screening has to be made obligatory in the NCD clinics. That means any patient reporting with diabetes to the non-communicable disease clinic has to have a diabetic retinopathy screening, unless otherwise his NCD chart will not be completed and the patient has to be called back for a diabetic retinopathy review. We expect to see a significant improvement in the detection rates with an increased awareness and increased public demand. And at the end of this, we expect that a democracy can never turn a Nelson's eye to a genuine public demand, that is, from the patient side, a request and a demand for screening their eyes for diabetic retinopathy. Thank you.
Excellently presented and an excellent work, sir. Thank you very much, and congratulations for such a nice work in nice way. So I've got a couple of questions, sir. So please be seated, sir. So what we, like since our childhood, we have been taught that Kerala has got 100% literacy rate. Then on contrary to that, you said that they are not aware about the health conditions. So any particular reason for that?
It's not that they are not aware, they just don't care. And many systems of alternative medicines thrive in Kerala. People, it's a very sad fact that many of our people, they still have less confidence in going for treatment unless they are affected. Unless they are symptomatic, they don't go for treatment, many of them. In spite of giving all the health education, the reluctance on the part of the patient, because they believe that they know everything, they don't turn up for treatment.
And so you said that your ASHA workers and those workers, the government deputed people, they go door to door to create the awareness.
Yes, these ASHA workers, they move around in the society. They have a lot of other work to pick up. Along with that, they also pick up diabetic patients and bring them over to the NCD clinics.
So it's just based on the history, or do they do a random sampling there as well?
Based on the...
So only if the patient knows that he or she is a diabetic, the ASHA worker can pick up and tell the patient to come to the center for screening.
Yes.
And so, like you showed in your pie chart also, that there was like how many patients they do turn up from the villages to the tertiary centers for their further evaluation, and like what is that dropout percentage?
Here I would like to bring another point. From the community to the NCD clinic, almost all of them turn up. From the NCD clinic to the base hospital, there was about a 33% dropout.
So that's a huge
and
amount.
then we followed up these patients and tried to bring them over to the base hospital for further evaluation and treatment.